like to thank Dr. Goldhaber because over the last several years now, we've begun to look more and more at how medications are prescribed and, more importantly, whether patients take their medications in the different settings where they're in control of their medications. And I actually think when you look at the data today, you will come away with a conclusion that we are in a bit of a crisis situation. So my objective today is to really give you some background, which I think is surprising and even staggering, in how much medication we actually use in the United States. I'd like to define for you, or give you a definition of medication adherence or compliance. I'm going to give you a fair amount of data on the scope of the problem and talk about the barriers in which patients have difficulties in actually managing or taking their medications. We'll talk briefly about some of the new options that are out there. I can tell you up front that we don't have a home run ball solution. As Dr. Budd had alluded to, it's very, very complex. We'll talk about some next steps and some conclusions. Sam has been very generous to allow me to give a story at the start of my lectures, and today will be no different. This is the story about my grandfather, Gregory Fanikos. He came to this country speaking no English at all and was a simple grocer, an uneducated person. He managed to have a number of children and grandchildren that have become educated in the United States, gone on, become doctors and lawyers, etc. But when he was, and he lived to the ripe old age of 96, which I think is amazing. But in his tail end of his life, he began to have difficulties. He developed atrial fibrillation and symptoms of congestive heart failure. He was on digoxin and furosemide, but warfarin as well as an anticoagulant. He developed some edema and needed to be hospitalized. When he came to the hospital, they realized he had anemia, and so he stayed for a 5 or 6 day visit to the hospital where we needed to remove some fluid from his lungs and actually find out what the causes of his anemia were. As is the routine in the hospital, he was visited by a dietitian who came to him with a menu and wanted to help him select his diet and what he was going to eat over the next several days. And in one of the days of his hospitalization, on the menu was pea soup. My grandfather had been told to avoid green vegetables because he was on warfarin, so he politely declined. The dietitian said, "We're famous for our pea soup. It's the dinner special tonight. You should order it." And he declined again. And when the meal arrived, as you might expect, there was pea soup as part of his meal, which he chose not to eat, and they took away later that evening. Well, the next morning, he was scheduled for a workup to see if he was actually having any gastrointestinal bleeding. And as part of that, as you might expect, they need to clear the GI tract, and so he was required to receive an enema early in the morning before he was taken for his procedure. My grandfather used to sleep in the fetal position, if you will, and so when the nurses came to see him at 4 o'clock in the morning to give him his enema, he was somewhat startled, as you might expect, and then went on for the procedure the rest of the day. The interesting thing is my dad and I went to see him later that evening, and he was clearly agitated and talking to my dad in Albanian, their native tongue. And as I went home with my dad, he started to chuckle. And I said, "Dad, what was so funny?" He said, "Well, your grandfather thought that when they came up to him at 4 o'clock in the morning, they were actually giving him the pea soup that he declined earlier in the prior evening." And so he was telling my dad that if you ever come to this hospital again, that you should, if they offer you medication, you'd better take it. Otherwise, they'll come up to you and they'll sneak up to you and give it to you in the middle of the night. So I think there's some sound medication advice there to talk about how do we get patients, whether they know about it or unwittingly, adhere to the regimens that have been prescribed. I talked about the magnitude of medication use in the United States. It's staggering. These are the numbers from the Center for Disease Control. If you look at any across the United States population, about half, if we divided this room in half of you are on or taking a chronic medication. Half of the U.S. population takes one medication, about a third of the population takes two, and about 10% of the population takes 5 or more medications chronically. That's a surprising number to me, staggering that the amount of volume of prescriptions and medications that are being used in the United States, and it should come as no surprise that if we look, about 90% of patients over the age of 60 are taking medications. So the medications are, in a sense, concentrated in the elderly population. There is no difference really between men and women. There is a predisposition, I think, that's based on income, but as you might expect, the elderly are typically those taking the medications. And if you look, again, at those patients that are taking 5 or more medications, about 40% of those dwell in the patients that are over the age of 60 years old. So our elderly patients are faced with taking a lot of medications on a routine basis. What are those medications? Well, for our purposes today, as Greg Piazza alluded to, we've got a huge explosion in the use of drugs that lower lipids and hypertension. But for those of you that focus on thrombosis, there's been an equally dramatic growth in the use of antiplatelet agents and the use of anticoagulants. So they are not unrecognized as being drugs that are frequently prescribed. Well, how do we define compliance, concordance, or adherence? Well, the politically correct terminology today is adherence. We use the definition as simply, it describes the degree to which a patient follows medical advice. Now, I'm going to focus on medications today, but if you think about it, it pertains to exercise, diet, laboratory testing. For those of you that are wearing compression stockings or require some sort of managed care for wound care for things like post-thrombotic syndrome, that's basically what we're referring to, the degree to which patients follow their medical advice. And as you might expect, we get tripped up from the moment a prescription is written all the way to the point where the patient has to take the medication. These are the types of problems that we run into. Oftentimes, patients won't fill a prescription. They won't refill a prescription. They'll omit doses. They'll take more than they should. They'll stop their medications when they shouldn't. They'll take their medications at the wrong time. I talked to my in-laws that are retired down in Florida. I found that they share medications. The elderly will share medications in their living condominium complexes, which I think is scary. And then, of course, taking things with medications, or taking medications with foods or liquids that you shouldn't. And we can go on, but this is the type of issue that we're following as a problem with medication adherence. What does it lead to? Well, the scope and the results are, again, staggering. It's estimated that about 125,000 deaths in the United States are related to problems with medication adherence, as many as 340 patients a day. And if you look at patients that arrive to our hospital with medication-related problems, about 1/3 to 2/3 are related to poor medication practices or poor medication adherence. When we treat patients with chronic medications over the long term, only about 40 to 78% of medications will comply with those regimens for chronic disease. So 1 out of 2 patients that are given a prescription over time will typically stop, have problems with medication adherence. And as you might expect, the cost to the healthcare system is huge, estimated at $290 billion. I showed you the numbers that the problems in terms of the number of medications is most acute in the elderly, and they are the most likely to run into problems. About 1/3 of patients never comply with their medications from the time the prescription is written. Another 1/3 will stop taking their medications completely, and even more concerning is about half of patients will make errors in terms of how they take their medications moving forward. About 1 in 5 never even fill their prescriptions. And again, you should recognize that the vast majority of patients that are elderly live on their own. They are not institutionalized, they're not in a nursing home, but they are the sole ones responsible for their own medication management. The consequences, patients show up at our emergency room, they show up at our physicians' offices, and you must recognize now to the clinician, we don't know if this is disease progression or if it's a failure of an effective medication to work, that you need to start your workup all over again to identify or diagnose what the problems are. And obviously, in terms of clinical consequences, you can see if a drug is intended to provide some sort of pharmacological effect, not taking that medication will lead to problems. In the setting of anticoagulants, obviously, it's thrombosis. For cardiac meds, it's like hypertension and arrhythmias. Antibiotics is a huge problem now for us in the hospital when patients don't finish their regimens because the antibiotics or the bacteria now become resistant, and those antibiotics that once worked are no longer effective. And then obviously, if you have teenage daughters like I do, you worry about things like birth control and the unwanted pregnancy. Who recognizes medication adherence as a problem? Well, this group called FICO is actually the organization that provides you with your credit score. If you have a credit card or a bank account, you have some sort of credit score that when you go to the bank to try and take out a mortgage or to take out a loan, they look at your credit score. This same company now, and you can see what the components of your credit score actually are. This same company now has come up with an adherence score where they are looking at different measures that they are readily public available information to see how likely you are to follow a drug that's prescribed. The score is based on a 500-point scale. They take things like age, gender, family size, and your assets. What does this mean? Well, think about it. If you have a poor credit score and you go to the bank, the likelihood that they will give you a loan is slim. More importantly, if you're a risk, the interest that they will charge you is going to be elevated. If you have a poor compliance score, I can only see that insurance companies will make you pay more for your medications because you're less likely to take them. So this is going into effect now and is available for many of the insurance companies. If we look at individual types of disease states, like myocardial infarction, I put this up here because, as Dr. Bart suggested, patients usually go home on aspirin, clopidogrel, a beta blocker, and a lipid-lowering agent. About a quarter of those patients didn't fill their prescriptions. After a month, about a third stopped. After 3 months, 1 in 10 patients stopped. And you can see that the performance over time is about 50%. Only about half patients take their medications on a routine basis. We can look at causes. This was data that came out of one of our groups at Brigham and Women's Hospital, looking at CVS pharmacies and the copayment or the cost that patients pay and their likelihood to fill a prescription. So as you see, as the cost of your medication rises, the likelihood that you'll fill your prescription within a certain period of time gets delayed. So cost clearly is a component to what patients do with their medications. And are there poor outcomes if patients don't fill medications right away? There certainly are. And again, something that Dr. Bart alluded to. These are patients that had a heart attack and a stent placed to reperfuse them. About 1 in 6 patients failed to fill their prescription on the day of discharge. What is the sequelae of that? Well, there was a twofold higher increase in death and myocardial infarction in those patients that delayed their prescription fill or actually never had their prescriptions filled versus those that did it in the same day. So the longer we wait for our prescriptions to be taken care of, the poor outcomes we see. And even under the watchful eyes of having a patient in the hospital, our nurses take care of patients in the hospital routinely. We did this study 2 years ago at Brigham and Women's Hospital where we looked at patients that were receiving venous thromboembolism prophylaxis, and I'll point to you the numbers right here in the middle, that only about 3/4 to half of the patients actually received all of the doses that were scheduled during their hospitalization period. So in order for us to prevent blood clots from occurring, we actually need to give these injections for the whole hospitalization period. And even under the eyes of the nurses and the nurses administering the drugs, we had great difficulty in performing that task. Not surprisingly, when you're talking about injections, when we looked into the details of those patients, by far, the most common reason patients didn't get their doses within the hospital is they simply refused to have them. That was a surprising finding to us because we just assumed that patients were getting all the preventative strategies that were ordered, and actually the patients within our own grasp and our own surveillance was simply saying they refused not to take the medications that were prescribed. As well, you'll see that Dr. Bhatt talked about this. All it takes is some simple events to tip patients into noncompliance. I put this up because he talked about nuisance bleeding with antiplatelet drugs. By far, that is the most common occurrence relative to alarming or major hemorrhage events, that those nuisance bleeds will cause about 1 in 10 patients to stop taking their medication. Clearly, if it's a big event, about half of patients stop, but simple side effects need to be considered. How long have we known about compliance as a problem? The old Surgeon General knew about it in the 1980s, and most recently our current Surgeon General, Regina Benjamin, has made it a point now to look at patient adherence to medication regimens as part of her watch. You'll see, and I'll talk about it in a few minutes, that she has a program that she has put together to help patients with compliance. We can look at the barriers. We know there are things like complex regimens. If we put a lot of drugs on board, that's difficult. People lead crazy lifestyles in today's day and age. I talked about cost, but I wouldn't discount the relationship with a physician to his clinicians, side effects, and the explanations to patients that we give them as to why they are taking their medications. Recognize, if you feel ill and you take an antibiotic, typically you feel better after 5 or 10 days. If we give you an anticoagulant or an antiplatelet drug, an antihypertensive drug, there is no discernible benefit to the patients. They are simply taking them on faith that there is going to be some event downstream that is going to be avoided. These are the complications that you, as the sociologists break down compliance into different categories. We can have identified communication barriers where people simply don't understand either the English as a language or have low functional literacy. There is the issue, as I suggested, about economic status. And then finally, are patients actually motivated to go the long haul and take their medications on a daily basis? Well, we've broken some of this down. This is work by Steve Baraletti. And in each one of these circles, we've managed to identify a way of trying to respond to problems that may occur in the individual patient. For some, it may be simple as providing an interpreter. For others, it's providing support, because many of the drug companies have indigent programs that will provide drug for free of charge. But as a practitioner, what I'd urge you is as you go into your practice setting, think about the obstacles and the barriers and whether there are vehicles in place that can be used to help these patients move forward. As a pharmacist, some of these interventions don't cost a lot of money at all. I'd like this study that I posed to you because the University of Michigan took patients that were taking seven medications, either once, twice, or 3 times daily, and in the baseline, they found that about 30% of those patients took their medication 7 times a day or more. And very few of them were able to organize their regimens into something that matched their daily schedule. So just by sitting down with a clinician, they were able to take a patient, again, with 7 medications and reduce their regimens into 4 dosing periods during the day at 8, 12, 6, and 9, whereas when patients were left alone, what you see is patients are taking medications numerous times a day. If you take a moment, you help patients organize their medications in their daily agenda, you can actually facilitate and make their medications easier to take. I talked about the Surgeon General. They have a great deal of information now that is rolling out on this program called Script Your Future. It provides patients with simple hints as to how to stick with their medications. There are patient diaries. There is actually a website where you can log on and send a message to your own cell phone every day when it's a dosing period, so you can alert yourself through this website. And as I suggested, the Surgeon General has made this a priority. Other tools that we can use, there is a whole bunch of different tools out there in terms of alerting devices. that you can buy that either ring like an alarm clock or have an alert built into the medication cap. This is a company locally. We can always give patients a simple diary so they monitor what they do. And again, you can even go to your iPhone, if you carry one, and download what is called Pill Phone. Again, a reminder that will send off an alarm to your cell phone to tell you when you need to take medications. And of course, other things like calendar packs, etc. We try to focus on getting patients to follow a habit. I put this slide in to remember if we start small, we worked with a patient of aligning their medication regimens around a 30-day period. Can you use a trigger, your alarm clock, brushing your teeth in the morning, walking the dog, watering your flowers, certain triggers that remind you to take your medications. And we ask patients to start slowly, work at 30 days, strive for 90 days and work forward, keep things simple. And then if you fail, don't be afraid to experiment and look for other triggers. The idea is to establish a pattern that you can follow on a day-to-day basis. We've worked very hard at the hospital. I talked about patients refusing their medications. We've worked on a study over the last year to try and improve the provider-patient communication so that they understand why their medications are being given and what the long-term benefits are, and to recognize that while some of these regimens are injected and they hurt, they actually don't hurt that much if you sit down and actually have to do it. So we did a study over the last year. We'll have results, I think, at this time next year or probably in April, where we actually sat down with patients in the hospital. We talked about venous thromboembolism, what the medication that is being injected does, why it's important to take every dose, and if they had any questions that we could respond to. So a dialogue back and forth in terms of establishing a relationship. We've even put together videotapes. I'll tell you, this is not pornography if you watch it, but it might be close to it. And I put this in because for me, this is an Academy Award and perhaps a ticket to Hollywood in the future. But if somebody like myself can give an injection into the abdomen, and we show this to patients, it's very simple. You can do it. It's not a difficult thing to accomplish. I put together an action plan because I think there's always a takeaway message here. We know that patients transition, and while they're in our grasp of the hospital, that's an important time to give patients and family instructions about their therapy before they get discharged. We play a role in communicating with the patient and who we are handing off to. So we talked about patients not filling their medications, so can we work that path cleanly so that the drugstores or the pharmacies that are filling prescriptions know these patients are coming? And then there's a huge role for those in the community to continue supplying support and education, reinforcement to get these drugs taken. And then finally, I'll mention the point about outcomes. It is incredibly important to help these patients understand whether the drugs are doing what they intended to do. So are your lipid levels coming down? Have you not had any episodes of clotting? Have you had any observed instances of nuisance bleeding? Can we help identify outcomes that may impact what patients do moving forward? So I took a few minutes longer than I had intended. The message I'll give you is that medication non-adherence is extremely costly, and I think it's going to be a real focus moving forward because we have so many patients in the United States on medications. I don't have a single strategy to give you. I think it's very complex, and you need to look at the issues that impact individual patients and then help strategize how they can overcome or remove those barriers. A major priority, I think the best practices are to promote behaviors or habits that patients can follow. We can fill gaps when patients don't know why they're taking medications and the benefits they provide. We can reinforce that on an ongoing period. And then finally, as I suggested, the patients are going to have to be empowered with many of these tools to carry forth into the future to make sure they take their medications. And with that, I'll stop. Thank you for your attention.